Now we're talking about the advances in the management of cancer pain. I bring greetings from my institute. I work at Cancer Center, IRCH of All India Institute of Medical Sciences, New Delhi. Now, when we talk about the cancer pain, the magnitude of the problem of cancer is really troubling. Almost 3 million patients are living with cancer in India. 10 lakh new patients are being added every year. And almost half of these patients have pain at the time of initial diagnosis when they present to the hospital. Almost 2/3 of these patients with advanced disease do have pain, cancer pain, and 1/3 of these patients also have pain even after they have received the curative treatment. So this means the cancer pain is really an issue, and we need to look into this matter so that each patient remains pain-free, whether he comes at the time of diagnosis under assessment, or it is getting cured, or even the patients who are advanced one. Because almost 1/3 of these patients would have moderate to severe pain, and pain-free is the birthright of each and every individual, and hence we need to look for the management of pain. But on the other hand, when we talk about the cancer pain, the neurophysiology is complex, and the optimal control of chronic pain in cancer relies on the understanding of various underlying pathophysiology and the molecular mechanisms which are involved. And this is the reason that more we understand the pathophysiology or neurophysiology of the cancer pain, more interesting it is with regards to the academic component. And that's why more and more updates and holistic management plans and various other options are coming for the optimal control of the cancer pain management. To start with, cancer pain is mixed mechanism pain. This means usually these patients would have the etiology of occurrence of pain or underlying pathology of pain will be from multiple areas, maybe nociceptive, neuropathic, and usually combination. And that's why we need to have best practice for the cancer pain management, which will take care of these complex mechanisms, multiple mechanisms, so that these patients get good pain relief. This reason for multiple mechanism or mixed mechanism is primarily because of the multiple presentation of this cancer. They can have direct tumor invasion into the local tissues. They could be the obstruction of the viscera, like bowel, like hepatobiliary system. They can have nerve compression and plexus invasion, maybe in the vertebral column, maybe in the plexus. They can have metastatic bone pain. They can have post-surgical pain or persistent post-surgical pain. After radiation therapy, they can have radionecrosis, they can have neural involvement, they could be inflammatory pain, they could be ischemia. Because of the chemotherapy, they can have chemotherapy-induced neuropathy, they could be paraneoplastic changes, they could be neuropathy or arthropathy because of the disease, because of the treatment. And hence, one or more than one mechanism may be involved in the manifestation of cancer pain. This cancer pain can present in various aspects. They have a significant affect component. They may lead to just not the physical component, but they can have other features also like anxiety, depression, anger. They may have social component, spiritual component as well. There are many guidelines which exist which talks about the cancer pain. They have been very holistically maintained. They're presented, and all these guidelines can be used for our clinical practice. Having said that, when we talk about the cancer pain, it's just not a pain. There is a concept called total pain, wherein we are talking about the multidimensional nature of the pain, which includes just not the physical component, but the cancer pain patients do have a lot of psychological, social, and spiritual aspect also. And hence it becomes essential to consider a total pain strategy for management of these patients, because the contribution of each component is specific to each individual and hence requires assessment of each, and each component should be addressed so that patient gets a total pain relief. The basic principles for this total pain management in a cancer patients would require an interdisciplinary teamwork approach to improve the quality of life, taking care of the side effects, and finally aiming at functional recovery of the patient to a meaningful life with good quality of life. Now, all of you must have seen this WHO ladder, which is primarily used for patients with cancer pain and its management. And the basic principles that by the mouth, by the clock, by the leader, individualized for the particular person, use adjuvants and attention to details, which could be the other symptoms and associated side effects. And this WHO ladder is one of the acceptable tool for cancer pain management, but not all the patients may be not fully treated, or the patient may not be tolerating it, or the patient would have some other things also that would require some other interventions. So almost 70 to 90% of these patients will be treated using this three-ladder approach of the WHO for effective analgesia. But then we need to remember that as I mentioned, that the neurophysiology of pain in cancer is a little complex, and hence multimodal therapies would be required using different group of drugs, which may be in the form of conventional analgesics or adjuvants that will take care of the pain. Not only this, whatever the emerging tool is the use of the interventional treatment of cancer pain. Many of these patients would have tumor or pain in a particular area which is amenable to intervention in the form of some nerve block, or maybe the use of implants that delivers the drugs continuously, and hence the toxicity or the side effect of a drug given orally will be reduced, because intrathecal drug administration will require a lower volume, lower dose, and hence these patients would have lesser side effects. Almost 10% of cancer patients have pain which is difficult to manage with these drugs, and hence these interventional therapies, which was earlier considered as fourth step, but now it is integrated into first, second, and third. Early intervention remains the key, which is providing a good pain relief to these patients. And these interventions include non-neurolytic and neurolytic nerve blocks. Non-neurolytic means the use of local anesthetic agents along with agents like steroids. NEURAXIAL drug infusion techniques, which could be use of catheters, or also use of drug delivery implants. And also more recently, in these patients who have refractory pain, intractable pain, implanted neurostimulations can also be provided to these patients for effective pain relief. The various nerve blocks depends upon the site where the cancer is, and an appropriate nerve or a plexus that can be blocked for it. And commonly used block are the celiac plexus block for surgery for patients having like cancer, gallbladder, pancreas, liver. Superior hypogastric block for regions like urinary bladder, uterus. Ganglion implant block for say like cea rectum, and splanchnic nerve for the pain in the upper abdominal region. Now these are the blocks which has very good effect. So once a diagnostic block has been given and confirmed that the originator of pain is from that particular plexus, a chemical neurolysis using alcohol or phenol can be given to these patients, so that these patients have a good relief for a prolonged period, as these neurolysis leads to Valerian degeneration to a large extent. It has a limited time because these type of regenerations can happen, and the tumor may further advance or metastasize, having pain at other sites. But this gives a very good pain relief whenever feasible. The other options, which is advancement for cancer pain management, includes the NEURAXIAL infusion of the drugs, wherein more drugs are infused into the epidural or subarachnoid space. This is a very good option for those patients who are refractory or they're intolerant to various oral or intravenous analgesic agents. Sometimes these patients may have intractable side effects also. And for this, a variety of other approaches can be used, wherein depending upon the life expectancy of the patient, these patients may have tunneled catheters with external pump, or these patients may also be having fully implanted infusion pumps in which a catheter is placed in the epidural space or maybe the subarachnoid space, and the infusion pump, which is filled with the drug, is implanted in subcutaneous tissue. In those patients in which the life expectancy is of a small duration, days to weeks, in this the percutaneous catheter is placed with an external pump, so as to give a good pain relief, so as to give them a good analgesia. The intrathecal drug delivery system, they are battery-powered, fully programmable pumps. It contains a drug reservoir in which we can subcutaneously put up the drug of required concentrations, and they can be set for a particular dosage to be delivered. They usually require anesthesia to implant these fully programmable pumps in the subcutaneous tissue. And the drugs, various drugs can be used like preservative-free morphine, hydromorphone, clonidine, baclofen, bupivacaine, jiconitide, and sometimes even steroids can be mixed into these drugs so that these patients gets a continuous delivery of these agents and hence provide good pain relief to these patients. So these are the subcutaneous pumps, implantable pumps, in which if you see this is attached to the subcutaneous catheter, which is implanted into the subarachnoid space or epidural space, and through this we can fill up the drugs as and when required, and whole this can be controlled through an external remote where we can set in and see how the response is. The doses can be altered as often as necessary, and the patient can deliver preset boluses via handheld device, and they can also provide the individualized requirement of these drugs can be titrated accordingly. The other advancement of pain relief in cancer patient is implanted neurostimulation, wherein the implants are fixed. These leads are placed for spinal cord stimulation using a dorsal column stimulation. This electrode is passed into the epidural space as per the assessment where the nerve or the dermatome, which is having the pain, where the peripheral afferent input enters the cord, and then this electrode is connected to a delivery device where an electric current is applied of a specific dose, and this provides a good pain relief to these patients. The best candidate for such type of implants are patients those who are having intractable, focal, isolated pain of neuropathic origin that comes under to a particular dermatome, wherein these can be implanted and the patient has good pain relief. With improving insights into the mechanism, neuroanatomical pain transmission pathways, increasing expertise in the interventional analgesic therapies, and with the emerging evidence for the safety, there is a rising call for early implantation of these interventions pain management in carefully selected group of patients who are not responding to the drugs well, who are having advanced disease. So this selection needs to be done, but early interventions provides a good quality of life to these patients and hence should be considered. So this means the care of a patient suffering from cancer pain requires a holistic approach, combining psychological support, social support, rehabilitation, and multimodal pain management in order to provide best possible pain-free quality of life. Patient education is also one of the important aspects so that we have a realistic goal of care for these patients so that these strategies can reduce the pain intensity. And we know that pain is the fifth vital sign, and hence this requires regular assessment. It should be integrated into the oncology management, and all patients should receive pain relief. Having said that, we also need to understand that we are able to manage majority of these patients with simpler strategies, but there will be a group of patients who will be really difficult to treat. And these difficult cancer patients probably has difficult, persistent, intractable, or opioid non-responsive population. And hence, these also needs to be darkened. Though these are small group, but again, these patients should also be provided some modalities so that we can even manage this type of complex cancer pain. The group of cohort where these patients will have difficult cancer pain includes where the assessment is not appropriate, the patient-related factors like young age, psychological distress, previous opioid use, high tolerance, history of addiction, impaired cognition, or pain-related factors like the difficult pain syndromes, neuropathic pain, breakthrough pain, opioid-induced hyperalgesia, phantom pain. So these are the categories of patient profile and disease-related concerns where the pain management sometimes becomes difficult, but yes, we have modalities and we'll be able to manage all these aspects. When we talk of the patient-related factors, the persistent pain has profound and widespread effects on patients' quality of life. It can affect mobility, the physical functioning, the sleep, the concentration, and unrelated pain can cause further psychological issues in these patients. Hence, it becomes important to understand this. Cancer-related pain is often underreported and undertreated, and there are many beliefs why this is being done. These are basically the barriers that needs to be concerned, that needs to be free. People are afraid of addiction, people are afraid of tolerance, they are concerned about side effects. But we need to educate the patient and the family members appropriately, and an appropriate approach and good selection of interventions along with pharmacology versus non-pharmacology will take care of these apprehensions. We also need to have good psychological approaches to pain management. It's just not the drugs or the interventions, a good psychological counseling of these patients, their personal beliefs and appraisals, the emotional reactions, coping behavior, the social contextual factors, they also need to be taken care when we provide them a total pain relief. Do discuss with the patient family members about the disease process, about the available strategies that we'll be using for these patient management. They should be encouraged, they should be empowered for all the treatment that we are giving to them. They can do a self-reporting, and hence the management becomes much better. The pharmacological procedural mechanisms and treatment of difficult pain syndromes depend upon what type of underlying etiology that is causing these pain. This could be neuropathic pain at times, or breakthrough pain, or phantom pain, or opioid-induced hyperalgesia. Now, when we talk of these difficult pain management syndromes like neuropathic, which can happen because of various manifestation of tumors, maybe compression, infiltration, maybe because of the toxicity of the chemotherapeutic agents, these patients can have neuropathic syndromes, and they are major issues. And these patients have at times refractory. They requires a lot of interventions. But yes, it's a clinical challenge. But yes, we are able to manage these patients having an appropriate approach. It has to be a multimodal management. We have to select appropriate drugs, including various adjuvants that we are available with. But at times, the use of in a selected group of patients, the use of opiates could also be an option. Neuropathic pain is reported to respond to opiates with an effect size similar to antidepressants and gabapentin and pregabalin, with no proved difference between various opiates. And hence, it becomes important that the selection of the drugs should be as appropriate for these patients. But then remember that these drugs should be selectively used in these for this type of pain. But having said that, many of times these patients do have the etiology or the underlying is a combined pain, and hence probably this will take care of the other aspects also. The other challenge in these patients and the recent consideration is the opiate rotation. Changing or switching from one opiate to another has been reported in many uncontrolled trials and descriptive studies to lead to the improved pain relief and or reduction in the toxicity of a particular drug. And hence, it can be used. For example, methadone. It is one of the good drugs where it has a mechanism of action by inhibition of NMDA receptors and monoamine reuptake, plus effect on activation of kappa and alpha reported receptors. So that's why it's provide not only a good analgesia, but also reverse the opiate tolerance. And this has been benefited in many patients and have a good impact on the neuropathic pain also. The adjuvant analgesic has a major role. It's, as I mentioned earlier, the multimodal management is good. Opiates are not only the magic bullets. Yes, they are important, but then we need to think of other adjuvants which are required for management of these patients. And the gabapentinoid group of drugs, including gabapentin and the pregabalin, are one of the important addition to the neuropathic component. The antidepressants also are one of the important modalities for management of these patients, as these enhances norepinephrine and serotonin mediated descending inhibitory output and possibly blockade of the sodium channels. These drugs are like tricyclic antidepressants, including amitriptyline and nortriptyline and desipramine. They have established efficacy in neuropathic pain, and I think this remains the first step of management for neuropathic pain. But yes, multimodal management of cancer pain is important because of the mixed mechanism. There is a recent evidence for the benefit of duloxetine in chemotherapy-induced pain for peripheral neuropathy as well. And the use of NMDA receptor antagonist has found its usefulness again, and there is re-emergence of the use of ketamine specifically for these type of refractory difficult pain. Lidocaine is another important drug that has been used for the difficult neuropathic pain, and they have been found to be useful for good pain relief in patients with neuropathic pain. Coming to the bone pain, again, these are many new drugs, interventions, pharmacotherapy has come up, and the use of anti-inflammatory drugs, bisphosphonates, calcitonin, donezumab, radiotherapy, systemic radionuclide therapy, and surgery are various options that can be provided to these patients for good relief of cancer pain. With the skill and compassionate use of these measures, even patients with severe pain can be expected to achieve adequate relief. So think of a holistic assessment, a holistic management, just not using the drugs. Denosumab, this is a targeted rank ligand inhibitor. It's a new therapy for prevention of bony pain. And hence, there are various studies which has found the efficacy of denosumab for its beneficial effect in these type of pain. Providing radiotherapy is also a good option, especially for bony metastasis. And when there is a localized bone metastasis, the provision of 1 or 5 grays of 5 fractions of radiation therapy to these sites can also lead to decreased edema and pain relief. The use of various radiopharmaceutical agents has also been found to be useful for decreasing the metastatic bone pain. And the use of agents like strontium, samarium, rhenium, these are the agents that has been found to useful in patients with bony pain. The surgical interventions like collapsed vertebrae, the interventions like vertebroplasty and kyphoplasty, they are the emerging strategies and has been found to useful in this selected group of patients. And hence these procedures can be undertaken in patients where they are having neurological symptoms with pain and hence can be taken care of. Opiate-induced hyperalgesia is a challenging task, and these patients would manifest pain even with the increasing dose of the opiates. And hence, this becomes a real challenge, and this usually results from neuroplastic changes in the nervous system, leading to sensitization of pro-nociceptive pathways, and hence this needs to be managed. So whenever you're treating these patients, if the effect of opiate treatment appears to wane in the absence of disease progression based on the clinical examination and imaging, they have diffuse allodynia not associated with original pain, and they have increased levels of pain with increasing doses, we need to suspect opiate-induced hyperalgesia. The treatment strategies primarily aims at individualization of treatment and strict surveillance, stop the offending drug, look for the opiate substitution, rotation as we mentioned, try to include the interventions, use of other adjuvant drugs that provide the decreased requirement of the opiates, and hence these patients can be provided good pain relief. Another challenge and advancement that has been done for cancer pain management is the phantom pain, wherein a patient perceives the pain in region of a body that is no longer, maybe the limb, maybe the breast, and other tissues which has been removed. Patient still feels pain even though they are not there. And the reasons are peripheral as well as central mechanisms, including neuroplastic changes that contributes to phantom limb pain. The treatment option for these requires a preemptive analgesia. These patients are started on gabapentinoids before the amputation happens. The selected use of multimodal regime is a good option. Based on the assessment, we can use the combination of opiates, acetaminophenes, antidepressants, anticonvulsants, MDA receptor antagonists, and calcitonin accordingly, and these provides good pain relief. The inclusion of other things, non-pharmacological treatments like transcranial magnetic stimulation, visual feedback, reflexology, TENS, and sometimes even the surgical destructive intervention and nerve blocks. There are the other interventions that can be done for these patients to provide good pain relief. Having said that, the challenge is there are many barriers to cancer pain control. I mentioned at the beginning, but these the key barriers exist from all strata, from patient and carers, from healthcare professionals, and from healthcare system. So we need to identify these barriers and try to resolve them so that all cancer patient can get good care, good attention, including various pharmacology, non-pharmacology, and support from the psychological aspect, social and spiritual aspect, in addition to the physical component, so that we can provide good pain relief to these patients, and hence we can improve good quality of life to these patients. There could be concerns about the side effect of the various drugs. There could be concerns about the inadequate awareness of the appropriate use of these drugs. There could be concerns with the inavailability of these things. And hence we need to create a system in which the patient gets the best of care, best of pain relief, and best of quality of life. We have to have a cancer pain management continuum using various available options, which are many advancements which has been now available with many drug therapies, interventions, other adjuvants that can be used to provide the individualized care to our patients so that each patient can get good pain relief. To summarize, cancer pain management strategies, when applied appropriately, carefully, and the right time, can contribute to enhanced pain relief, reduction of medication use, and markedly improved quality of life. And hence it becomes essential, it becomes a responsibility of us that each cancer patient has a full right to get the symptoms. Today we have talked about the cancer pain management, but again, we have to not just to talk about the physical symptoms, but we have to target the other symptoms also. These patients can have perceived pain because of the other symptomatology like nausea, vomiting, neurological deficit, and hence targeting these aspects becomes equally important for providing these patients a good pain relief. Thank you so much.